Laparoscopy it's a big word. My CEO normally jokes and says it's a tongue twister. So essentially, if you can allow me to combine minimal invasive and keyhole. So minimal invasive, that means we are cutting small holes. So, and now keyhole actually describes the size of the holes. So the holes are the size of a keyhole. So, and whatever we are putting in there, they're instruments. So the instruments, again, are the size of a key. So you put them in, you put in a camera. The beauty about the camera is you can have the camera look at different angles. So the camera allows you to be able to maneuver around now the patient.
So welcome back to yet another inspiring episode of Pulse Check, where we amplify voices that shape the future of healthcare. So today we are honored to have Dr. Dennis Muriithi. He is an award-winning gynecologist and a laparoscopic surgeon. His innovative work is transforming women's healthcare and redefining surgical excellence. He is here to tell us more on minimally invasive surgeries. Without further ado, Dr. Muriithi, welcome very much to Pulse Check. You won an award the other day.
Yes.
Congratulations.
Thank you.
Tell us more on the award.
So the award was by the American Association of Gynecological Laparoscopists in the US, and they actually gave us 2 awards. So the first one they gave was for physician from an emerging country. I won that on my personal capacity. And then the foundation of the AAGL has almost like a grant opportunity for 2 organizations in the world. And the Hem Practice won that grant opportunity. So what they are looking to do is be able to support organizations that work towards improving women's health care through laparoscopy. And that's where the Hem Practice came in.
Congratulations. What does that award mean to you as a person, to Kenya as a country, and to Africa as a whole?
So the first award was called the Harriet Hassons Award. So that award allowed us me specifically, to be able to travel to the US and be able to attend the annual Congress for the AAGL. So this was the 2024 Congress, November last year. So it was the first time of me attending a Congress of that size. You see America in TV every day, but getting to experience it hands-on is very different. The Congress was in a building called, I think it's called Ernest Young Place. And the building itself was on almost 4 acres. So having to experience laparoscopy in such a grand environment, in such an advanced society, because now you're looking at robotics, how guys are doing robotics, guys are doing some very advanced things. It's a challenge for you as a surgeon. So you go there and you feel like we're not doing too badly off as Kenyans. And then you go see world-class work, and these guys are doing some magnificent things. And it's not even because of the equipment, it's the dedication. You go listen to some of the stories that they share, you're actually inspired. You listen to some of the surgeons who overcame and were able to push laparoscopy to levels, even being able to form that organization, the AAGL. It took a lot of sacrifice and dedications from the American surgeons, and it inspires you. So even when you come back home, you're coming back home with that dedication. So that was now the one we got from the Harriet Hassons Award. Now, the one we got for the foundation of the AAGL, that one was specifically for the Hem Practice. Let me just say, I didn't win that on my own. The Hem Practice is an organization, and there are a lot of people involved. So for the last 3 years, we've been doing laparoscopy in Kenya. So as part of our Lap on Wheels initiative. So we've been doing a lot of free surgeries. We've done over 300 free surgeries. This is in Kiambu, in parts of Nakuru County, parts of Machakos County. But Kiambu County has been the biggest beneficiaries. So we would use our mobile equipment, we'd go to a theater, and all that the theater needs to offer us is just the anesthesia machine and the bed. So you would come in with a fully fledged team. So the team would come, they would set up, we would operate. And for 3 years, that's all we've been doing. And it's been more of a passion project. So we're doing it because we love what we are doing. And we could see the changes it was bringing in people's lives. So for about 200 surgeries we've done through now still our Lap on Wheels initiative. But as we were supporting doctors, we've got 51 doctors in our network, general surgeons, gynecologists, urologists. So they would invite us for their private work. So they would pay us, of course, not the market rates, but partially. So we would take our equipment, they would be able to do their surgeries, and with the support of our team, you see, laparoscopy is a team initiative. It's a team sport. Messi is not Messi without his team. So it doesn't matter how good you are. So without a supportive team, you're just as good as your team. So now, when a surgeon comes in a new environment with a highly experienced team, now this is what we would be able to offer. They're able to do some very complex surgeries, and they are able to have to bring changes to the society. So now, because of the Lap on Wheels initiative, that's what won us the award from the AAGL. Now, AAGL recognized us for that work. So they came in and they've supported us. So they're supposed to be sending in surgeons to Kenya to be able to help with the training. Because on top of us just offering their laparoscopy equipment, there's also an aspect of training. So because we realize 51 doctors, they're at different levels of their surgical skills. So we have our own locally made laparoscopic pelvic trainers. They're called endotrainer pelvic trainer. So the endotrainers, we use them to train the doctors. So the AAGL is supposed to come in, support us with surgeons who are experienced, who can be able to come in and grow the team. They've also supported us with a grant to be able to buy some instruments. And they'll give us a donation of an office hysteroscopy. So hysteroscopy is, in a simple way, it's an endoscopy of the uterus. So you find that in Kenya, endoscopy of the uterus is done in a theater environment. And because it's done in a theater environment, it makes it a very expensive procedure.
Sure.
So one of the things that we will be doing as a hem practice, being able to offer office hysteroscopy. That means the office hysteroscopy is cheaper, faster, without too many complications. So people who have polyps, people who have abnormal bleeding, people who have keep losing pregnancies for apparently no reason, can be able to have that diagnostic procedure done because now of the support of the AAGL and because now of the hem practice. So if you combine all that, plus now the training, we're able to impact the patients and we're also able to impact the doctors. So it's a two-pronged approach whereby our objective is to be able to change the industry.
Okay, you've talked about the hem practice and the Lap on Wheels. How do you separate the two?
So they are not separate entities. So the Lap on Wheels is like almost like a CSR arm of the hem practice. So the hem practice is a social enterprise.
Okay.
So a social enterprise, that means a huge chunk of the money we make ends up going back into the free things that we do. Okay. So it goes to support the Lap on Wheels program. So the Lap on Wheels program is part of our training initiative. So our training initiative, we have a training lab that has 10 training boxes or 10 training stations. And we focused on laparoscopic suturing. So when a surgeon masters laparoscopic suturing, they move from being just regular laparoscopic surgeons to being advanced laparoscopic surgeons. So what we were doing is we're moving these surgeons automatically. Okay. So from the on-site, that they need to know how to be able to suture. The simplest way to define surgery is the art of dissection. This is just cutting, and reapproximation, joining. So any surgeon does that. We do the joining using sutures.
Sure.
So now a beginning surgeon just does the dissection part. You can put in the camera, you can look around, you can cut here and there. But now when it comes to now the reapproximation, and that's where there is a problem. Us as the hem practice, using our endobora training boxes. We're able to teach the surgeons how to be able to do that reapproximation. And once we've been able to get them to that point of being able to do it in the lab setting, our Lap on Wheels program kicks in. So assuming we have a doctor from Nakuru who has come in, so they've gone through our training, so they've used our endobora training boxes. So we have a hybrid system. So they come to us for, so the current program is they come to us 3 weekends, and then the other days they do it hybrid. So they're at home. So once they've been able to finish the suturing part, we follow them to Nakuru. So now we have equipment and the truck, we drive all the way to Nakuru. They organize a camp in their location. We set up and we operate patients in their location. This gives the surgeons a bit more hands-on, because see, when you're operating in your own home turf, you're more comfortable. And these are your own patients.
Sure.
So it's different as compared to telling the doctors, you come to us and operate from our own setting. No. Using our equipment, using our team, set up, get a camp, we will come with the equipment. And we will train doctor, we will help you to perfect your training, because you've already mastered the beginning of it. Laparoscopy is not a very difficult skill to learn. The way I normally explain it is that you have drivers who are very experienced, comfortable with automatic cars. So this is someone who can crisscross their way through Thika Road with the automatic car. So you're telling them, now we need to transition you from this automatic car to this manual car. So it's just another way of operating. So just being able to know that when the car makes a certain noise, change to gear 2, change to gear 3, change to gear 4. This is how you accelerate. This is how you maneuver. So once they are comfortable, they actually end up becoming better. Probably I use the analogy of cars. I enjoy driving manual cars. I own an automatic car, but there's a thrill that comes to driving a car that you're actually in full control of. Because that's what the manual car actually allows you to be able to do. So now with laparoscopy, same thing. You've moved this doctor who is very experienced, and then you've given them much better view, because laparoscopy gives you a highly magnified environment. So they're able to take different angles. Can they be able to see upside down, right side, angulated, regardless of which angle you want to see. So they're able to have all those angles. They're able to zoom in, see minute blood vessels. So once they're able to see minute blood vessels, they either avoid them, coagulate them. It makes the surgery quite meticulous and really enjoyable. So that's essentially what we are trying to be able to push doctors to be able to get them to be able to get to that point.
And how long is the training?
So the current one we have just for the lab training, that one will take 8 weeks. So 8 weeks, 3 weeks on site. The rest we'll do hybrid. So they'll be at their own location. So you come in, we start you off. So we start you off by giving you at least an introduction, what is laparoscopy, the equipments that are needed. We've got partnerships that we have been able to make. So using some of the partnerships we have, we're bringing them in for the training bit. Like now, I talked about AGL amongst the partners we are working with. We have partners in Italy. We have some general surgeons also from the US that we are partnering with. So they partner with us in the training bit. So once we get the theory part done, we start them off with the hands-on bit. So we've taken that skill of suturing. It's a bit of a frustrating skill. So we've taken it and broken it down to small pieces. Swallowing it in smaller chunks makes it much easier for the doctors to be able to master it. So they come in, and now in 3 different weekends, they'll come in the 8 weeks. The rest we'll do online. So we have a one-on-one encounter online. That's also, and then they also have a logbook. So the logbook allows them to be able to clock in a certain number of hours on the training box. This is just a numbers game. This is just amount of time spent on that training box equals skill improvement for the doctor. So that's essentially what we are doing. Conditioning their minds not to feel overwhelmed by laparoscopy and conditioning their minds in such a way that they'll be able to make it routine. So start off routine. The same way they say, if you're able to go to the gym for 21 days straight, then it becomes a habit.
Sure.
So can we be able to make this very difficult skill become a habit for these doctors? And that's essentially what we are looking at. And in the process, we end up impacting the patients in their own communities. Because, of course, the home practice is doing that, but still, we are limited. We need to be able to expand the number of people who are actually doing what it is that we're able to do.
What's the criteria?
For who can join?
Yes.
So we've made it as open as possible. You see, laparoscopy is just a skill that someone needs to have. It's just another way of doing surgery. And our dream or our hope is that we can be able to expand our reach to up to the guys who are in medical school. So the 4th years, the 5th years, and the 6th years. By the time they're graduating from medical school, they are coming out with the skills. So there are local universities we are getting into MOUs with, so whereby we train their students. So by the time they finish doing the undergraduate bit, they already have skills in laparoscopy. So that means by the time this person is going to do their postgrad, they are very proficient in doing laparoscopy. And this is how we actually intend on changing the entire industry, such that laparoscopy becomes the norm and not the exception. It's become something that people just get in Nairobi, and it becomes expensive. So once we make it commonplace, it stops becoming expensive. It becomes more accessible.
Sure. Yeah. What are some of the expectations that these trainees should come with?
One, coming in with an open mind, that we are here to learn. Two, they should be willing to clock in the hours. You see, now telling someone you must clock at least 20 hours in this training box. There's Kaufman's rule on mastering complex tasks. So, initially we would say if you want to become a master in anything, you do 10,000 hours. So research has shown it's not very practical. It's not very possible to do 10,000 hours. So telling them, now Kaufman's rule says if you clock in 20 hours, you stop being a beginner, and now you reach that point. Now at least you're not a master yet, but now you are proficient enough to be able to proceed on your own to the point of you becoming a master. So being willing to commit that time is actually what will help them to be able to move from this level to now where we hope them to be able to get.
Sure. And to our patients, let's teach them on what laparoscopy means.
So laparoscopy it's a big word. My CEO normally jokes and says it's a tongue twister. She's a project manager. So it has many names. It's laparoscopy, minimallinvasive surgery, keyhole surgery. They're all talking about the same thing. So essentially, if you can allow me to combine minimal invasive and keyhole. So minimal invasive, that means we are cutting small holes. So, and now keyhole actually describes the size of the holes. So the holes are the size of a keyhole. So, and whatever we are putting in there, they're instruments. So the instruments again are the size of a key. So you put them in, you put in a camera. The beauty about the camera is you can have the camera look at different angles. So depending on how you position it, how you hold it. So the camera allows you to be able to maneuver around now the patient. So laparoscopy, as the name suggests, normally applies for anything that's done in the abdominal cavity. So for general surgeons, they do laparoscopy. For urologists, they do laparoscopy. For gynecologists, we do laparoscopy. Now, the word laparoscopy, it's because the camera we use is a rigid camera. But now when you go to other places, now when you're working with orthopedic surgeons, now theirs is called arthroscopy. Now the word scopy means just camera. So now arthro is now the orthopedic surgeons. Now, when you go to guys who are dealing with stomachs and things like that, then theirs is called endoscopy. If you look now, if you work with guys who are doing now the colon, theirs is called colonoscopy. So it's just a big word, but literally just means a camera plus something else.
Sure.
So now for us now in gynecology, we do laparoscopy. And laparoscopy has opened up in a way that there is no single surgery in the field of gynecology that cannot be done laparoscopically. Let me just put a disclaimer. There is obstetrics. This is treatment of pregnant women, and there is gynecology, treatment of non-pregnant women. Now, obstetrics, application for laparoscopy in obstetrics is limited. I mean, of course, we can't do a cesarean section laparoscopically. But everything else can be done laparoscopically. So from removing cysts, to unblocking tubes, to removing fibroids, to removing sick uteruses, to working with patients who have endometriosis. All this can be done laparoscopically. Working with patients who have ectopic pregnancies, all this can be done laparoscopically. Its application is endless. Right now, I think in the last 2 years, there's a new field of laparoscopy. It's called neuropelviology. And this is now for gynecologists. Now, neuropelviology, there are guys in Italy who now have taken that training, that skill of laparoscopy, and they've applied it to the spinal cord. So they are helping patients who can't be able to walk to be able to walk. So they are putting pacemakers on the spinal cord, and the pacemakers help the patients to walk. So every day we are discovering newer and more applications for laparoscopy. Doctors in India and other countries do transplantation of uteruses laparoscopically. So a patient comes in for one reason or the other, the uterus is very sick, can't work, and they're able to get a donation. You'll carry a baby to term, and that uterus was transferred laparoscopically. So its application is endless. Just because of that magnification, it allows you to be able to do very minute, detailed things, very meticulously, and you can be able to achieve so much.
Take us through the preparation. How do you prepare your patients?
So let me talk about the commoner procedures we deal with. The commoner procedures we work with is patients who have blocked tubes. So for the longest time, I think even by the time I was coming back from medical school, we knew if a patient has blocked tubes, send them to a fertility specialist for IVF. That was what we knew. Now, when we came into the field of laparoscopy, application for patients who have blocked tubes improved, such that we're able to work with patients who have blocked tubes and block the tubes because of now the magnification. So the magnification allows me to be able to see where the blockage is. I'm able to maneuver around. So now someone who has blocked tubes, we'd come in, we would have that conversation. The first thing is being able to tell them, okay, this is what we intend to do. We intend to be able to have a look at your uterus. Now, putting a camera inside the uterus is called hysteroscopy. So we'll put in the camera inside the uterus, depending on where the blockage is. The blockage is the corneal. So this is like the shoulder, where the tube starts. So if the blockage is at the corneal, there's a catheter we normally put. So we put the catheter hysteroscopically, and we literally push dye. So the dye actually works by opening that tube. If it doesn't open it, we'll actually see the dye go up to a point. And where you see the dye has gone up to that point, that is where the location of the blockage is. So you're able to bring in your camera and zoom in. And now you're able to do now the minute surgery. You cut that couplet which is blocked, and you reattach now the fallopian tube. So the open side, and now you remove the blockage. And now you rejoin the two tubes. Now you have a complete tube which is open. And these patients are able to carry pregnancies to term. Not once, not twice, but as far as they want. So this is something that we're able to do. And being able to see the outcome of our surgeries is really, really encouraging. Like I said, we've done a lot of free surgeries. And amongst the surgeries we've done is now those ones for tubular blockage. I had a colleague of mine call me the other day, and she was telling me now a patient came into her office. She had not seen this patient for almost a year. And the patient walked in carrying the baby, and the baby had the doctor's name. So the mother comes in and says, "Uni mtoto wako." So this baby is called Maggie, because you are the one who made this happen. Yes, after I have struggled for 5 years, we've not been able to get the baby. Now we've just been told, go get IVF. IVF costs an arm and a leg. I mean, there is an application for IVF, because even us, there's a point that we can't be able to reach, and we have to send you to an IVF specialist. But being able to bring joy to these women really encourages us to be able to continue doing what it is that we are doing.
Sure. Are there moments where you get in laparoscopically and then you switch to the traditional surgery? So
that used to be the teaching when I was in school, when I was doing my postgraduate. So when I was doing my postgraduate, the teaching was, if you go in laparoscopically and the surgery is too difficult, switch to open surgery. Now, the reason you'd be told to switch on to open surgery is because during open surgery, you can touch and you can feel. So now the touch, the touch feedback is the reason that we would be told, just switch back to open. It will be a better surgery because you have the touch. Now, thing is, when you're doing laparoscopy, you also have the touch. I can be able to touch with my instruments, and I get tactile feedback. So I touch and I know this is a hard part, this is a soft part. But when I switch to open, essentially what I have done is I've taken away my magnifying glass. So it's like I wear spectacles. I can see very clearly with my spectacles. So I decide, no, this surgery is too difficult. And then I remove my spectacles and I want to, of course I can't see you. So taking away my magnification, taking away my better vision, because now with laparoscopy, surgery is all about exposure. So exposure now is how much can I see? So for me to get that amount of exposure in open surgery, I would need to put such a big incision. And in laparoscopy, all I need to do, because we know we put gas, and the gas just gives us a very good big space for us to be able to work in. And I'm able to move from one side to the other. Like I said, I'm able to go upside down. It's like taking your car to have the exhaust fixed, and the mechanic decides to put it on 3 stones, versus taking it to a mechanic who has that hole that you walk under. The hole that you walk under, I mean, of course, you have that exposure, you can be able to see. So there is no way you'll be able to switch that this procedure has become so difficult when we are under this hole and we are standing and we can see clearly. And now you say, no, let's take this car and put it on 3 stones. Maybe that one will be better. I don't know that you understand. Yeah. So anytime you move from laparoscopy to open, you have made an already difficult surgery more difficult. So with experience, we've learned how to work in the environment we have and appreciate the environment we have. In fact, we joke and say, if a surgery is too complicated open, close up, switch to laparoscopy. Oh. Not the other way around.
Not the other way around. Oh, I thought there was you saying that if it doesn't work this way, we're going to switch this way.
So the only time I would switch that way is now when I'm working with, in a situation whereby there's bleeding, and the bleeding is a lot.
Okay.
And I'm not able to access the bleeding to be able to stop the bleeding fast enough laparoscopically.
Okay.
So if my knife is faster than my camera, then that I will opt for the laparoscopy, for the open surgery. But if my camera is already in there and I can see where the bleeding is, all I need to do is just catch the bleeding. Oh. And I'm able to now change and move around.
So tell us about your longest procedure.
That's a bit of a difficult question. In my growth as a laparoscopic surgeon, I think what I find myself is that anytime I start a new level surgery, let me clarify. So you've got level 1, 2, 3, 4, 5. So anytime I move from one level to the next, that surgery that moves me from that stage to the next usually takes a long time. The first time I did my first ectopic pregnancy, it took me about 3 hours. One, I didn't have the right equipment. I didn't have the right. We didn't have the steps memorized as a team. Remember how I mentioned that this is a team effort. So they didn't know what is supposed to come next. So we were in trial for 3 hours. Luckily, the patient still woke up and went home the following day. That's the beauty about ectopic pregnancies. My next procedure was now doing a hysterectomy. That only took 4 hours. So 4 hours was moving from, again, team doesn't know what comes next. You're the only one who knows what the surgery looks like, what needs to be done when. So anytime you're moving from one surgery to the next, that transition is not easy. So now we can do an ectopic in 30 minutes, or 15 to 30 minutes. You're in and out. The team already knows what it is that is needed. Even in terms of what instruments you need, they're already there. But when you are starting, no one knows. They're there waiting for you to ask for the next instrument to give instructions on what energy should be used and things like that. Right now, we've already developed a routine that we're able to walk in, the patient comes in an ectopic, 15 minutes, 30 minutes, we're in, out, gone, done. Patient awake, goes home the same day. Hysterectomy right now, we can do under an hour. This moves from 4 hours to under an hour. Myomectomies was the same thing. I think my first myomectomy, it took me almost 6 hours. Luckily for me, the anesthesia time, the hospital, everyone was patient enough to be able to wait. But now with time, you realize you move from being able to do 6 hours to now being able to do 3 hours, 2 hours, 1 hour, 1.5 hours. But with every single transition, I would still find myself going back to the training box. Like now my transition from doing laparoscopic hysterectomy to doing laparoscopic myomectomy, that transition, I needed to spend a couple of hours in the training because now I need to not just be able to stitch, but now be able to stitch fast enough. Because when you're doing a myomectomy, we normally use a drug that constricts the blood vessels, vasopressin. So when you inject vasopressin, it stays for 45 minutes. So I need to be fast for the vasopressin not to wear off. So I need to have controlled the bleeding before that time runs out. So with every new transition, there is a difficult step that we need to overcome. Right now we are doing endometriosis surgeries, and there was also a hard transition between from now doing just myomectomies to now being able to do endometriosis. That transition is not very easy. It takes time because now the team needs to know, everyone needs to know what are the steps, what are the instruments that are needed to be able to have everything running smoothly.
How about the recovery time?
So the recovery time tends to differ from patient to patient, but standard, what we've realized is 24 hours after the surgery, everyone is up and about. In fact, when a patient walks in, they walk in without the catheter, or they walk out, we've removed the catheter. So immediately someone is awake, they can walk.
They can walk.
And then we do such a fine job with the pain management because, again, there are two keyholes. They're tiny, tiny holes. So we normally use blocks to be able to ensure the patient is not in pain. In fact, we were joking the other day, when someone is awake post-op, we've removed their uterus. We're saying even if they start wanting to do sit-ups, they can.
They can.
Because there is no pain. So they wake up, within 24 hours, they can be able to be up and about. And for most patients, actually the only thing that would stop most patients from going home is that most relatives don't even know what to do with their patient.
Sure.
We had a situation the other day, we had a patient who came to us with an ectopic pregnancy from one local facility in Nairobi. So she had just informed her relatives that I have an ectopic pregnancy. We did the surgery at 5 o'clock. Between 5 and 6, we had finished the surgery. 7 o'clock, I had written the discharge summary. So the relatives were informed at 4 o'clock. So 4 in the morning, that's when they were given the phone call that she has an ectopic. And then now they are wondering at 6 o'clock, we've not even had a meeting as a family to decide what to do about it. and you've discharged her. So what do we do? Whose house is she going to? Who's going to take care of her? So they decided to keep her for another 24 hours as they figure what is happening. But she was up and about.
So a patient can actually go home
The same day.
the same day.
Yes.
That's interesting.
Within a week, most patients are able to go back to their regular activities and to actually be able to go back to work.
Wow.
Yeah.
That's interesting. What are some of the misconceptions you would want to debunk regarding laparoscopy?
One, it's possible to do laparoscopy. People tend to think that it's a very complex thing that you need to go to very big hospitals in Nairobi for it to be done. No, we're able to do it locally. And we have the necessary skills and equipment to be able to do it locally. Secondly, there is that notion that's a very expensive procedure. We are working hard to ensure that it stops being an expensive procedure. The other thing is people tend to think that because it's a new procedure, there are a lot of complications, dangers. It's not. It's a fairly safe surgery. It's just another way of doing surgery. And that's why I use the analogy of you're working with a driver who is experienced, can crisscross their way through thicker road, but with an automatic car. So now this surgeon is already experienced. All they're doing is they've chosen not to use an automatic car. They've chosen to use a manual car, and they have much better control of this car when it's a manual car. So the surgery is actually safe, if not safer than open surgery. Because everything you're doing it in a magnified environment, and you can see. You can see what it is that you're doing. Yeah.
What are some of the challenges that you face?
Acceptance, especially amongst medics. Like I said, anytime we transition from one surgery to the next, people tend to look at it and say, if someone was there when you were spending 6 hours doing a myomectomy, they have this preconception that myomectomies take 6 hours. So they don't sit down and ask themselves, why did this surgery take 6 hours? Can it be done in a shorter time? And in actual sense, yes, it can be done in a shorter time. The same way, even when we were starting to do open surgeries, my first cesarean section took me almost 2 hours. And now I'll do a cesarean section in under 30 minutes. You have to start somewhere. And the medics, once they get to that point and they accept that laparoscopy is not difficult, it's not a complex thing, because they tend to see doctors struggle. The sad part about laparoscopy is even open surgery, when you're operating, there are only two people who can see what you're doing, you and the assistant. In laparoscopy, there's a very big screen in the middle of the room, everyone can see. So if the surgery is difficult, even the guy who is cleaning,
You can see.
you're struggling. So the cleaner knows that this is a very difficult surgery. So in fact, we joke and say, if you have, if you're someone who is affected by pressure, laparoscopy is not the best technique for you to be able to do, because everyone, you're literally performing to everyone who is looking at you. And then the video is actually recorded. So it can be shared later with other people. So people will be able to come back and look and see the surgery was hard, or you were somewhere on a learning curve. So medics need to be able to get to that point and say, this surgery is not hard. We need to be able to give the surgeons more time for them to be able to grow their skills, for them to be able to reach that point that they can be able to do these surgeries laparoscopically. And this is why we actually invested in a training center, because the training, the skills you gain in a training box, you can very easily transfer them to a patient. That's why I said when I did my first myomectomy, it took 6 hours. I went back, looked at the videos, saw what steps that I didn't do correctly, sorted them out, and then went back to the training box and literally now started timing myself to ensure that I'm able to do this step that I was taking 10 minutes. Can I be able to shrink it to 3 minutes? Can I be able to shrink it to 2 minutes? What steps can I be able to shave off? And now I am practicing in a box at home. So without the pressure. So with time, the surgeons become better and better and better and better. And there are procedures that can't be done open. Endometriosis can't be done open. Endometriosis can only be done laparoscopically. Because now you need the magnification for you to be able to identify the location of these nodules. If you do it open, you won't see anything.
The thoracic ones?
Even those ones you need the camera, you still can't be able to operate without the camera.
Wow, that's very interesting. How do people find you?
The hem practice, we have our offices at Maisha Heights. Maisha Heights is opposite Pizza Inn. This is in Thika Town. We are off Kenyatta Highway. It's called Kenyatta Highway, yes. Opposite Kenyatta Highway. Building is called Maisha Heights, 3rd floor.
Oh.
Yeah.
You yourself, how can we get in touch with you? We need to do a lot of consultations.
So one can be able to find me at my office. We also partner with one of the local hospitals here called Muriithi Hospital of the Sick. So Muriithi Hospital of the Sick, I normally have a clinic there on Tuesdays, so I can also be found there. I think those are the 2 main places you can find me. Yeah.
Are you on social media?
So yes, I'm on social media. The hem practice is also on social media. I'm also on social media as Dr. Muriithi at the hem practice, or Dr. Muriithi. Should be able to find me. I'm on Facebook, I'm on Twitter, and I'm also on, I'm not on Instagram, I'm also on LinkedIn.
Oh.
Yeah.
So thank you so much for coming here on Pulse Check. And congratulations again.
Thank you.
You're doing a really great job. You know, when we saw you hitting the news, personally, I was very excited, and most of us were, and we were commenting, oh, that's our own. You know, everybody wants to be associated with whatever it is that you're doing. You're doing great. And to our viewers, thank you so much for being with us. We have come to the end of our episode. Please make sure you follow us. Like, share, give us your comments. Let us know what you want us to bring to you next. I've been your host, Pauline Gure. Until next time, see you then.